tentorial as well as infratentorial intraaxial locations surrounded by rim of hypointensity, likely representing perilesional edemas. These are predominantly seen in the cerebrum, parietal lobes, cerebellar parenchyma. Yeah, I would also like to see these altered signal areas on T2 weighted images and followed by post-contrast imaging.
Okay, you can pick any image which you want. Yeah.
This is the coronal T2 image of the same patient demonstrating these lesions to be T2 iso to hypointense surrounded by rim of hypointensity and significant perilesional edema. There is no hydrocephalus, no significant midline shift. And I cannot appreciate any uncal herniation. Assess the enhancement pattern, I would like to take the post-contrast images of the same. So these lesions are demonstrating almost complete. I'm trying to scroll through the images. They are demonstrating, most of the lesions are demonstrating smooth ring-like complete enhancement. Many of the lesions are located within the white matter. However, few larger ones are located in the corticomedullary junction. Again, I cannot appreciate any hydrocephalus, or there is no evidence of ventriculitis. I cannot appreciate any meningeal or leptomeningeal enhancement, except a focal area of enhancement of the meninges along the larger ring enhancing lesion on the left frontal region. The infratentorial intraaxial lesions are exhibiting the same pattern of post-contrast enhancement. So if I would like to know the history of the patient, if the history is suggestive of infective, I would categorize as multiple tuberculomas, since these are predominantly T2 hypointense and representing the morphology of the granuloma. However, these can be, if there is any known primary, these can represent as multiple intraaxial suprainfratentorial metastatic deposits. I would also like to screen whole of the neural axis. If the diagnosis is going towards the conclusion of tuberculous etiology, I would like to screen I would contact the referring physician and request them to screen the patient for pulmonary COX as well. Pulmonary tuberculosis, the families should also be screened, and the patient should have a detailed workup for tuberculous etiology.
Patient has a known case of breast carcinoma.
So if the patient is a known case of breast carcinoma, these are likely, in keeping in view the history, these are likely representing suprainfratentorial intraaxial metastatic deposits with no significant meningeal enhancement, excluding the possibility of meningeal deposits. I would also like to look at the bones of these patients, to know if there is any metastatic deposits. The patient should have should have a staging CT of CT thorax as well, but patient is already in stage 4, and I would also like to see the diffusion restriction for these lesions.
Why?
If these are ring enhancing lesions, keeping in view the history of positive CA breast, ideally these should not be demonstrating these should not be reflecting diffusion restriction versus granulomas or abscesses. As when we compare, we can rule out the
What are you
possibility
gonna
of.
do next if I say that these are the breast metastatic deposits? Now, what is the next line of treatment or suggestion from radiology?
The patient should have a complete, if it's a known patient, the patient should have a detailed staging CT for, and if there is any other metastatic deposit in the lungs or nodes, that should be biopsied, and the patient should be referred for MDT discussion for further management and planning.
Okay. Next case.
I've been provided with frontal chest radiograph of a skeletally mature patient demonstrating inhomogeneous opacification in the left lower zone. I can see linear areas of surgical emphysema in the left-sided chest wall. Soft tissues noted as well. There is a tilted tube noted with its tip in the left medial lower zone. I'm suspecting a thin linear area of pulmonary pleura along the left lateral chest wall, concerning for pneumothoraxis, and bilateral apices are also devoid of bronchovascular markings. Concerning for bilateral pneumothoraxis, I would immediately contact the referring team or emergency department from where the patient has come to sort after the detailed history. If there is a history of trauma, I
There
would
is no history of
also
trauma.
look for. There's no history of trauma. There's also mild tenting of the left hemidiaphragm. There are also patchy cystic areas in the bilateral hilar locations and reticulations as well. This can be secondary pneumothorax, secondary to some cystic lung disease. I would compare it with the previous imaging as well, if available, or further advised for HRCT lungs.
Okay, what is this?
This is a central catheter for the chemotherapy.
Okay, what is the name of this?
Portacath.
Okay, so considering, as you mentioned, that you think there is
Mhm.
some disease, and do you reach any differential for this?
So if it's
Patient is
hmm,
young and having multiple like recurrent chest infections.
So
One other
if the
sentence
patient
maybe.
is young with, sorry,
Yeah, yeah. Okay, yeah. Go
this
ahead.
is the X-ray of the same patient.
No, no, no. You go ahead with your last sentence about that case, and then we'll move
Okay,
on and we'll
so
discuss it
young
later.
patient with recurrent infection, cystic changes, pneumothorax, so likely cystic fibrosis, and I would further evaluate with HRCT and relevant investigation for cystic fibrosis,
Okay. This is the next
sweat test,
case.
etc. So these are the frontal projections of ankle joint of a skeletally immature patient with unfused physeal lines. I can appreciate an oval-shaped radio-dense area along the medial aspect of the distal fibular diaphysis. No, that is
Can
never
you
mind.
show with the arrow, please, what you are
No,
mentioning?
I'm sorry. That is just a projectional
Okay.
thing. So I cannot appreciate any discrete fracture line passing through the cortex of tibia, fibula, or fibular shaft or tibial shaft. The styloid process of the fibula and tibia are unremarkable. A thin radiolucent line is seen to traverse through the tibial plafond, concerning for any fracture with surrounding sclerosis.
Where it is? Please mention with the arrow shown.
Can you see my arrow, ma'am?
No, I can't.
Uh,
Where it is? Like explain it. Where you are mentioning where this? Yeah, yeah. Now I can see your arrow. Okay.
you can
Yeah,
see, okay,
yeah,
this
yeah.
one, ma'am,
Okay. Okay.
with surrounding sclerosis.
Mm-hmm.
So I would like to know if there is any history of fall or trauma.
Yes, there is a history of trauma.
I would like to raise the concern with the primary team and request them to further go ahead with a CT of this area to rule out any underlying fracture.
Mm-hmm.
And it is not crossing through the physeal line. It is within the epiphysis.
Mm-hmm.
So it is, if I'll classify according to the Salt and Harris classification.
Mm-hmm.
Um, Type 2 probably, and I would like to further evaluate it on the
Okay,
basis of.
okay. What are the types, please? Recall them.
Type 1 is just the slipped phases.
Okay.
The two in 2 there is the fracture line passing above the epiphysis,
Is it
above the
above?
physeal line.
Is it above the physis?
Below. Yes, it is
Then you
below.
mentioned it is two.
Yes, yes, it is below.
Then what
Below
is
and
this?
not crossing the physeal line.
Then what is it?
Uh, 3.
Okay. And what are you gonna do next?
I'll inform the orthopedic surgeon for intervention, and I also would like to further confirm it on CT without contrast of this region of the ankle joint.
Okay. Next case. Patient presented with sudden onset of cough.
I've been presented with frontal chest radiograph of a relatively young patient demonstrating mild haziness in left upper zone as compared to the right side. The um, I can see the patency of the tracheal lumen. However, distally, the bronchi are of the left main bronchus is of relatively uh, narrowed lumen. I can appreciate mild rib crowding on the left side in left upper zone, bilateral CP angles, cardiophrenic angles, and right-sided lung parenchyma grossly appear normal. There is no abnormality within the right hilum. So, considering the history of acute shortness of breath and a young patient, and with this X-ray finding, my first priority would be to rule out the possibility of foreign body inhalation.
Mm-hmm.
I'll immediately inform the physician, and I would also like to assess is it on lateral projection if available, and I would like to correlate with.
Okay.
Um, so these are some radiopasties are noted. Like I need to check with the radiographer as well. Are these artifactual
These
or?
are projectional. Yes, these are
Yeah.
artificial.
Yeah. So there is mild adenoid hypertrophy. Rest of the upper airway appears unremarkable. I'm unable to clearly define the lower airways, but there is the left lung haziness is redemonstrated on this X-ray.
Okay. If this is a foreign body aspiration, as you suggested, what should be the next step?
Immediately inform the pediatric team on call, and this should be taken into account, and they should evaluate the patient and try to retrieve the foreign body by. They should try to retrieve the foreign body by doing bronchoscopy.
Yeah. So do we have further time or should we start discussing? Candidate two?
It's only 1 minute remaining, ma'am.
Okay, so we should start discussing these four
Sure,
cases.
ma'am.
Yeah.
Sure.
Okay, first of all, this case. Yeah, it is a foreign body aspiration. And you should have to mention that in the cases of foreign body aspiration, your immediate answer should be after that. You did really well in this case. There's no problem in like you explained very well. There's a lucency and everything was right. But you should not ask for the lateral chest X-ray
Mhm.
because in the exam, real exam, you should ask for decubitus views or and you have to explain that you know how you will interpret that decubitus views that in the case of foreign body aspiration in this case it's on the left side, so whenever the left side will be on the dependent side, even dependent or the upper side, both on the both ways that it will remain hyperlucent, so that examiner knows that you will he knows that you know that what you will look into decubitus views. Do you understand my point? If you are
Totally, ma'am.
asking for any other view, then you should know how to explain that view. Number one. Number two, you should be confident in saying that in children, if there is a because in any other case, I did not give you history. Only in this case, because in such cases, history is very important of one word that I said such it's a sudden onset of cough. So right away you reach the diagnosis of foreign body aspiration. So you should be confident in saying that I will pick up the phone and call the referring physician or the pediatric team on the emergency department for and refer him for the bronchoscopy. No hesitation in saying, because in children it's very important to save the patient at that time, because it's not necessary that we could see the foreign body on the x-rays. Sometimes it's lucent and you can't see on it. So otherwise it was well explained film. There was nothing much to add on this. But regarding the last case, uh, it is, yeah, this was your last case
Sir,
before
ma'am,
that third.
yes.
You did not ask for contralateral imaging, did you?
Oh, no, no, I did not.
No, because this is the point where examiner sometimes I did not help you in this case, because there are examiners who will not help you in saying, do you want to see other films? No, they will keep on agreeing to that what you are saying, and you are thinking that you are going very well on that film, because this is not Salter Harris type 3 fracture. Because in this view you can say, but when you see this view, what is your
Oh,
opinion
right,
now?
ma'am.
It is, it is a slipped, it is a oblique
It
fracture.
is
Now what it
going
is?
through the physis as well.
Yes, as well. So it
Uh,
is sagittal, it is transverse, and it is oblique coronal as
right.
well. So what is now?
It's type 4 going above and
Type,
below and passing to the.
yes, yes, it is type 4,
Oh,
and its further name is triplane fracture. So sometimes they will help you during the case, and sometimes they will not say anything. And when you are out of the examination and you room, and you said you did pretty well, because you really did well on that film, but you did not ask for further things, and they will not try to help sometimes, it is what you are doing in that 15 minutes. So I deliberately did not help in this film. And
right, ma'am.
and you should know about the types very well without any confusion, because first you said it is below, and then whatever you are saying, you are creating either problem for you, or either it is good for you. Like you are creating your viva on your own pace. If you are, like, you want
Right,
to do
ma'am.
well, just say those words which you are confident about.
Right, ma'am.
So yeah, this was the triplan fracture, and they could ask you after that what are the types of Salter Harris, just like I did ask. And the next question should be very, very clear, that you should say with confidence that I will go for CT scan. In these cases, CT scan is must for the treatment plan. So you have to say that I will go for immediately arrange the CT scan, and also convey my finding to the orthopedic on-call team.
Right, ma'am. Thank you.
Yeah. And okay, this case, yes. The moment you see portacath in any chest X-ray, you should be knowing that why it is there. It is for the long-term treatments, or for the chemotherapy patients. You did really well by picking up this tube, by picking up the pneumothorax, but it was not bilateral. It was unilateral left pneumothorax with a portacathein, and you also picked these cystic changes. But you were not confident in saying that it could be cystic fibrosis, and whatever. I just encouraged you to say, and then you said about the things. Otherwise, you were going to not confident about this film as well. But the moment you see a young patient with portacath, with cystic changes, with pneumothorax, so it is straight away going towards the cystic fibrosis. So what is the what should be you doing, like in the next after explaining what should be, what you should be saying is that I will ask for the previous imaging or previous chest x-ray to compare the findings, number one. And also, the next question from the examiner can be, what I can ask you now, is it a if it is a pneumothorax, it is emergency sort of pneumothorax, or what you convey, like
Ma'am, we
what
have
how
to
you,
check the patient if the patient is stable, and if at an interval films the pneumothorax is not progressing, that we are not, then we are not going to, then we'll keep on monitoring the pneumothorax. If it progresses, then we are going to put a tube for range of the
yes, but
air.
there is still a criteria. If you don't know, you have to check on the internet today and from the articles, that there is a criteria of some measurement from this wall, chest, lateral chest wall to the wall of the pleura, to measure when we should insert a tube. And
Right,
this is
ma'am.
very important. It is usually asked in the exam.
Right, ma'am.
What is the criteria if the patient comes to you with the shortness of the breath and you did X-ray and there was a pneumothorax? Did you straight away suggest the doctor on call that put the chest tube in, or would you suggest anything by your looking into the X-ray? So there is a criteria. Please check from the latest
Ji, sure,
criteria
ma'am.
today. And yeah, this is a cystic fibrosis. And next question should be like, now I will ask you that what are the complications of cystic fibrosis in GI?
Pancreatic insufficiency, chronic pancreatitis,
Mm-hmm. What else?
and gallstones, gallstone related pathologies.
Anything else?
And also it can affect the hepatic parenchyma
Anything else?
and ileocecal junction abnormalities, and of course meconium ileocecal syndromes leading to obstruction.
Yes, small bowel obstruction syndrome. Okay. So you should have to, they can ask you about GI related abnormalities. So you should be remembering this
Right,
for
ma'am.
the viva. And remember, this viva is usually for those cases in which you end up the case and you have a time left, then they will ask you. If you do not end up the case well, and you say anything like in the Salter Harris one, you said three, and then I said, okay, is it three? Are you sure? Or this, if these things happen, then there is a less chance for them to ask further questions for the case because you are still on the film. Do you understand?
Right,
So
Gigi,
yeah,
totally.
yeah. So this was the case. This you presented very well, but there were two things I mentioned on the book that you just lingered this case on. I know it's a long case, like you have to see further images. But when you when I told you there's a known case of the primary breast cancer, then you again went to the DWI and ADC without any reason. Like there is not enough time for a single case to be checking on all the MRI images. Even if I said this is the case of breast cancer, you could wind up that case. Just I wanted to mention that you can you have to save the time for other imaging as well. And one other thing is that when you were mentioning the, like, first you mentioned the sagittal image, and then when you were on the axial image you again mentioned hydrocephalus and every other finding on that image as well. So try
Right,
to avoid the repeating of the same negative findings. It will cost your time. Do you understand?
right, ma'am. Noted,
Yeah.
ma'am.
Otherwise, you did really well in this film. Just you did really well overall. Just a bit of the things I mentioned to just
Thank you
for your
so much for
improvement.
your valuable feedback, ma'am. Thank you so
Okay.
much.
Okay. Thank you. So now you will keep the time and candidate too. Are you there?
Totally,
Okay, some
yes.
yeah.
Okay. So yeah, your time starts now.
Okay, so I've been presented with the frontal chest of a skeletally mature patient. First of all, I'm going through the image. So here I can see that there is a retrocardiocapacity, which is showing lobulated margins and central lucent area. There is no associated calcification. Um, I'm looking at the rest of the lung parenchyma. Um, there is some reticular shadowing. Oops,
Uh,
the
you
screen
you,
gone.
you minimizes it. Sorry. Leave the mouse. Leave the mouse, please.
No, I don't have mouse, ma'am.
Okay, I don't know. Candidate
Uh,
one, are you still on the?
yes, 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 I'm getting it.
Sorry. Okay, yeah.
Okay,
Can you
so
see? Yeah.
yeah,
Yeah,
ma'am.
please leave the control, candidate one. Okay, yeah.
Okay, so so in some, I'm looking at the rest of the lung parenchyma. There are a few reticulations. Reticulonodular changes are seen in bilateral lungs. They may be projectional, or patient may have any history of. Um, so in my routine practice, I have a little bit zoom up the image and windowing to confirm
Mm-hmm.
these findings. So about this retrocardiocapacity, if the patient is in, I am looking at the soft tissue. I could not find any soft tissue pathology. The bones appears normal. So in summary, the findings are of solitary pulmonary nodule or mass. So this could be due to any carcinoma. If the patient is a known case of any cancer, it may represent metastasis. So I will further evaluate this patient with CT just to confirm this finding and further characterize this lesion.
Okay. If you can mention the shape of this opacity.
So it's somewhat oval or with lobulated margins, and I'm seeing some lucency in it. It may represent a tubular, a rather tubular structure.
Yes. So anything,
Yeah.
any differentials in your mind?
So
Patient does not have any primary.
okay, so AV malformation is my then top differential in this case.
Mm-hmm.
So I will check any other opacity. There is no further opacities or nodule in the rest of the lung parenchyma. I'm suspecting calcific density over the liver, but it's just I cannot confirm on this windowing. So patient may be a known case of hereditary hemorrhagic telangiectasis. So
Mm-hmm.
further evaluation or comparison with previous any film is
Mm-hmm.
suggested for further confirmation.
And what you will advise next?
CT chest and abdomen with
Mm-hmm.
contrast, and also CT brain to look for the presence of any aneurysm, or there's also chances of there's also chances of embolization of infection, or if the patient has symptoms, so then further evaluation of the CT brain or MR brain is suggested. Okay, this is a frontal projection of the wrist joint. Here I can see that there is a large lucent lytic area with expansion. It is involving the metaphysis and extending into the subarticular location. It is showing multiple septation in it, and the margins, medial or lateral margins, appears slightly thinned out, and at some places I'm suspecting erosions. It is showing slightly wide zone of transition, and I'm looking for the presence of any pathological fracture in it. I could not find any, but in my routine practice I will also check the orthogonal view for confirmation of this, and any soft tissue component, and for periosteal reaction.
Mm-hmm.
So on this film, my differentials are GCT, or as the epiphyses are few, so aneurysmal bone cyst is less likely. The other possibility of GCT is my top differential in this case. So further, I will compare with previous, and further evaluation with MR to further characterize this.
Okay. You
So
can
I'm
ask for remote,
requesting,
please.
yeah.
Yeah.
Okay, so I've been presented with CT brain, axial section, plane. So first of all, I'm going through the images before describing them. I could not find any hemorrhage in the suprainfratentorial region. There is an area of low density which is involving the right insular ribbon. So I'm looking at the lentiform nuclei or coordinate nuclei for the involvement. There is no involvement of the deep gray matter. I'm looking at there is no mass effect over the frontal horn of the lateral ventricle, and I'm going down to look for the presence of any further herniation. There is no crowding at the foramen magnum. Now I'm looking for any MCA done sign on the same side. So I cannot find any dense artery. So I will check the clinical history of the patient, how the patient is presented. If the patient is presented acutely, then further evaluation with MR brain is suggested to further
So what is
confirm
your
this finding.
differential?
Okay, so low density area in the inferior cortex region. This could be a cortical based lesion, like primary brain tumors like oligodendroglioma, but I cannot find any calcification in it. So this can be ganglioma or yeah. So these are my differential in this case.
You are saying me that there is a possibility of SOL, and differentials are regarding SOL. Any other differential?
Okay.
Patient
So
presented with short history of confusion and a mild fever.
okay. So I'm looking at um, the rest of the. So in the case of fever, it may represent an infective etiology. So I will further evaluate this patient with MR brain to confirm these findings.
Mm-hmm. Okay, we'll go for the next case. Link the mouse, please. Yeah.
Okay.
Mm. Patient had recent history of surgery.
Okay. So I've been presented with. I'll start from one side. So I've been presented with axial CT abdomen in the portovenous phase of a patient who have been presented, who have recent history of surgery. The first thing I can see that there is slight intrahepatic cholestasis with uh, may I little bit zoom up the image because the size of the image is quite small.
If you can try to zoom it.
Um, okay. So I can see that the CBD is also appears dilated, and I'm suspecting a dense focus, or this is just a vessel. Um, okay, so I will further I will check the rest of the um, findings, and I will come back to this. So um, there is also dilatation of the um, gallbladder, I'm suspecting. So I will just trying to check whether this is bowel lobe or a gallbladder. So I'm just tracing the stomach and
Patient had open cholecystectomy.
okay. So the dilated structure just adjacent to the inferior margin of liver is not continuous with the stomach or duodenum, so it may represent any collection
Mm-hmm.
or so as a patient have recent cholecystectomy. So in my routine practice, I'll also check the coronal images
Yes, please.
to thank you. So on coronal images, I'm just focusing on the same area. It again shows intrahepatic cholestasis with dilatation of the common hepatic and common bile duct, and it is just want to trace its lower end. It
Mm-hmm.
is showing just tapering of the lower end, and there is I'm suspecting few densities within the CBD, and I'm also going to the same area of interest which was I saw on axial images. Yeah, this is an area, small, thin walled area with relatively high density but I can see valvular connivente, so it may represent adjacent dilated sentinel loop. So I'm looking for the presence of any pneumothorax. Is the patient have recent history of or pneumoperitoneum, sorry, or any other complication, as the patient has open cholecystectomy, so I'm suspecting uh,
And it has been three weeks now since he had open cholecystectomy and now presented with abdominal pain, and then we had a CT.
okay, so structure of the CBD and or choledocholithiasis are differential in this case due to present dilatation of the CBD and intrahepatic cholestasis. So
So what is that structure? What you were mentioning?
just trying to trace its communication with, but I cannot find any
Any
communication with
differentials in
the
your mind, or we should go to next case then?
um it may represent a bezoar, or yeah, it may be like retained content, retained what should I say, gauze piece.
Yes. So
So
what we are gonna say that word is?
it just slip out of my mind.
Okay, next case,
um
please.
okay.
No problem. Next case. If you turn off the findings, like the zoom bit,
Okay.
because it's so small now.
Ma'am, 1.5 minute
Yes.
left.
We can have a next quick cases if she will be quick. Yeah. Yeah. And okay, don't go next case. Go on ultrasound of this image, and then we'll go.
Okay, so here I can
And
see,
this is the ultrasound.
yeah, so
Yeah.
there is significant posterior shadowing. So it is showing a
Yes.
metallic object in the this region. So this is
And you have skipped that word, yeah?
yeah.
It's fine. Leave the mouse, please. I'll
Okay,
go quickly to the next case. Yeah. This is a quick case. It's a patient presented sudden onset of unconsciousness.
okay. So first of all, I'm going through the images where I can see
There.
that there is
Yeah.
a large area of hypodensity which is present involving the pons and cerebellum. It is causing effacement of the fourth ventricle, and it is also involving the both like right and left. Oops, it's jumping.
That's fine.
So yeah, it is involving the both sides.
Mm-hmm.
So I can see the dense
Mm-hmm.
basilar artery
Mm-hmm.
tip. So this represents a tip of the basilar artery syndrome. So I will immediately convey the finding to the referring physician and IR team. If the patient is a window of 12 hours, so thrombectomy is suggested in this case for further
Okay.
management.
So I think their time is also up. So we'll start discussing from this case. You did really well in this case. You picked up the finding, but the one thing I have an objection that don't say those words which you are like you have to pause for that. I think they will go for thrombectomy. We are not here like to say this in the real exam. Fine, like thing, you have to just say you picked up the finding, you described thing, and you said it's a basilar artery thrombosis leading to this, and I will pick up my phone or I will convey my finding immediately, as you said, to the stroke team. That's it.
Okay.
So that when you end the exam findings, then there will be time for from examiner to ask you further questions or go to the next case. In the FRCR exam, the time is your boss or key, you know. If you lose the time by just lingering the case yourself, then you will lose your chance for having more cases in less time. Yeah. So
Okay.
it was well defined. There is no problem in that. So it's this yeah. In this case, I did help you because in such cases, examiners do help when there is the significance of history, because you can't reach without history properly to the cases. But you ultimately you reached. This is Gosi Paiboma. Yeah.
Yeah.
Yeah, you were not having, but in such cases, if the typical word slip from your mind it doesn't count, and the examiners understand this, it's anxiety and stress at that time. but but you the ultimate aim is to get the findings right, and and then you convey the findings rightly to the referring clinician or surgeon or whatever the case is. This was also good. You explained very well in short time. This is good. There's nothing much to add. And always pay attention to the one word history if it is given. Not in all the cases the examiner will give you history. In the case in which there is a little history, it means that it is very important for that. When you start the film explaining the film, that when you say there's a axial slices, a contrast and CT scan of abdomen and pelvis, axial slices have been given, and I have given the history that patient had a open surgery or cholecystectomy 3 weeks ago, so that you remind yourself and the examiner as well about the history when you are with your opening sentence. Do you understand?
Okay.
Yeah, it helps you in your thinking process again. And examiner also likes it when you repeat a little bit of it, that you are listening to the history and you are working to that film, to that case according to the history which the examiner has given you. Yeah, this is the case. I'm just little bit why it's not scrolling. Yeah, this is the case. You should reach it instantaneously, because when you were explaining, I thought that you are there, but then you give the different differentials. But regarding the hypodensity at insular ribbon sign, there should be first two differentials in your mind. What it should be?
Infarct and
And
mm,
herpes encephalitis. One case.
okay.
You can never miss it. And then you explained beautifully that there is no involvement of the basal ganglion. I thought you are there, but you are still not there.
Mm,
Because this is the differential point between the herpes encephalitis and the infarct. It is limited to this area, not involving the basal ganglia, and then I gave
mm,
you history. Then I gave you history to more direct you fever and short history of confusion. And still you were on the SOL. So in these cases, time is important for the patients. You have to say that I will immediately convey my findings so that they can. And the first next step is CSF evaluation in such
mm,
cases, so that they can
okay.
start antiviral, or if they want to do any. So this you little bit messed up here because you were not saying the differential correctly, and there is a little bit hemorrhage in here within this density as well, if you see now.
Okay. Yeah.
So yeah, in such cases, the differential of infarct, you have to mention herpes encephalitis or encephalitis with that must. Um, yeah, this was pretty much well explained by you. And in such cases, when there is no further film, just a plain film, they want you to explain it well, and you did explain very well. You did said expensile, you did said subarticular location, zone of transition, like every periosteal reaction, fracture present or not present, what is the matrix, is it single, is it multiple, whatever. So you have to uh, po- point those in plain films. Otherwise, if you will not explain well and you say straight away it's a explain film, and with one or two words you say it's a GCT, you are losing your marks for that film. If it is 8 marks for that film, you will reach by 6 or 5.5 in that. But if you explain this as you explained, you could reach 7.5 in that film if you are explaining. So just to my emphasis here is not for only for you, for all who are listening, that if the case is easy, they don't think that they're giving you 8 out of 8 or 7 out of 8 or 7.5 out of 8 if you are just saying the diagnosis. If you are explaining it well at that film, easy film, then you are getting the marks. Otherwise, you will only get a passing marks for that film. You did really well in this, but I don't think so. You mentioned much differential for this that.
No, one differential only.
Yeah, but again, you are right in that if it is so typical that you could say, okay, it is it, but which still, for the sake of exam, give in MSK films 2 to 3 differentials,
Okay.
because there is GCT transformation of ABC as well, and different other
Mm-hmm.
chondroma and everything can also change into GCT and ABCs. So they are like, you should mention.
Okay.
This was your only this case. A little bit problem was there because you said straight away to the I think MET or mass.
Solitary pulmonodular mass,
Yeah,
yeah.
because I think it is quite visible, like a tubular appearance, and you didn't pay attention in the beginning. Maybe I don't know, because of the image is small, or it's projectional. You're right, but
Mhm.
if even if you are giving a solitary pulmonary nodule, always keep an eye, or like make a habit of putting the more differentials. And it's no problem in saying that it looks like a mass, or but examiner, if there is examiner who don't want to discuss it further, he could just change the film, or change the pass the film
Okay,
without leading to your the final diagnosis. It is a pulmonary AVM, and the rest of the questions are obviously you already mentioned. When you reach that, you already mentioned its association and everything. But next question after this, the examiner would ask, what are the associations, what is the diagnostic modality of choice for this, what is the diagnostic modality of choice for this case?
CT chest
Yeah.
tube contrast.
Yes, CT, and what is the treatment? Transcatheter embolization. And they
Yeah.
can ask you complication, and in complication you will say heart failure, paradoxical cerebral embolism, abscesses, and that's how you end the case. But again, if the plain films are there, you have a chance of questions in the end if you explain well, and then end the exam, and the like show the examiner that I have done my job. I have given the explanation, findings, DD, and what next, and then you'll be quiet, and the examiner will ask the question. Yeah, but
Okay.
overall you did really well.
Thank you so much, ma'am.
Yeah. Okay, so who is our candidate 3?
Assalamu alaikum, ma'am.
Walaikum assalam. So candidate 2, please keep the time, or anyone who is keeping the time, please.
Yes,
Okay,
ma'am.
I'll keep.
Okay, your time starts now.
Yes, ma'am. This is an X-ray frontal projection of a skeletally mature patient of a left hip joint, in which I can see that there is a narrowing of the joint space along the superior lateral margin of the joint, of the hip joint, with mild marginal sclerosis. And there's widening of the joint space along the medial aspect. The contour of the femur appears to be normal, and I cannot see any other lesion in the head as well as the proximal visualized femur. Uh, there is an area of focal calcific density within the left half of the hemipelvis. Um, so, can I have the history of this patient, and can I have the history of this patient now?
Patient presented with lower pain in the left hemipelvis, so they had X-ray first.
Okay, so ma'am, there
It's a
are
30-ish, late 30 age of the patient.
okay. I mean, this is a young patient. Ma'am, other than that, I would like to see the other orthogonal film if available.
Yes, please.
Okay, again, I can see that there are multiple calcific densities that are projected over the joint, the left hip joint. They are well defined and appear to be calcified. So, primary differential include osteochondromatosis. Uh, and I can also see that there is a bony defect along the superior lateral margin of the pubis. This could be projectional
This is
if the
projection.
patient. Okay. So, ma'am, I would like to go for the MRI of this patient, if available.
Okay.
Uh,
Okay. Okay, we'll go for the next case.
okay.
Just leave the mouse. Yeah. Sorry. Yeah.
Okay, this is X-ray abdomen, frontal projection of a of a skeletally mature patient, in which I can see that there are multiple dilated loops of the small bowel that are centered in the abdomen, and I cannot see any gas within the pelvis. I cannot see any free air under the diaphragm, and I cannot see any other sign of pneumatosis in this provided image. Uh, I'm looking for any air in the region of the right, in the hepatic region, to rule out if there is any intraportal venous gas. But I'm
there is no definite evidence. So this is likely a case of small bowel obstruction, and I will immediately inform the finding to the referring physician and would advise CT abdomen with contrast.
Mm-hmm.
Okay, shall I start?
Yeah.
Well, okay. So,
This is a CT of that case.
yes, ma'am. This is a CT abdomen with contrast of the same patient, in which I can see. Let me scroll through the stack first, and then I'll comment.
Mm-hmm.
Yes, I can see that the hernial orifices are intact.
Mm-hmm.
And there's free fluid in the pelvis, and I can see that multiple small bowel loops with fluid filled, and a few of them are showing hematosis. I can see that there is a thickening of the bowel loop
Where?
here, ma'am. Here, this one,
Okay.
the
Mm-hmm.
right iliac fossa. I can see that there is circumferential thickening of the bowel loop with involving the ileum and the ileocecal junction
Mm-hmm.
with mild fat stranding, and tiny lymph nodes may be there. Uh, so this is most likely the transition point that is causing proximal small bowel obstruction. I can see gallstone as well within the gallbladder. So, ma'am, keeping in view these findings, I would like to, in my routine practice, I would like to see coronal images as well as I would like to
Please.
see the lung window
Yeah.
to rule out any free air. Uh, yes, ma'am, these are coronal images of the same patient. There is some difficulty in scrolling actually.
Mm-hmm.
I think there is some collection as well in the anterior abdominal wall on the right side that
Mm-hmm.
has internal necrotic component and peripherally thick walls. So this could be an abscess in the anterior abdominal wall. Uh,
You want
actually,
to check it on axial or the
yes,
same place?
yes, ma'am. Yes, I can see that here it is.
Mm-hmm.
Yes, I can see that there is a collection. There is a the bowel loop is adherent to the anterior abdominal wall, and
Mm-hmm.
there is a collection within the rectus muscle anteriorly.
Mm-hmm.
Uh, 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 there's no herniation of the. I'm looking if there's any bowel loop. Yes, ma'am. There is suspicion of herniation of bowel loop as well in
Mm-hmm.
this region.
Mm-hmm. So, if the
Uh,
bubble loop is going there and causing
so
the bubble obstruction, so what is the
ma'am,
diagnosis?
this is likely ma'am incarcerated hernia, small bowel anterior abdominal wall hernia that is leading to um,
Yeah, and
small.
what is the name of this?
Uh, ma'am, uh,
Okay,
uh,
we'll come back to this. And how will you tackle this case further now? What you're gonna do if there's bowel obstruction?
ma'am, I will immediately inform the finding to the referring physician, and this patient require immediate surgical consultation to prevent bowel ischemia and further.
Okay, this is the next case, please.
Okay, I'm provided with frontal projection, lateral projection of a knee joint of adult patient, in which I can see that there are patchy areas of lucencies and sclerosis that are diffusely involving the distal end of the visualized femur, and
Mm-hmm.
there is a subtle periosteal reaction along the anterior aspect of the femur as well. Similar findings are seen in the proximal tibia, and I can see that there is reduced bone density as manifested on the patella and visualized fibula. So
Mm-hmm.
I would like to see other orthogonal views, and if this patient has a history of fever and chronic sinuses discharge, so this could be a case of chronic osteomyelitis. Can I see this other
Okay, you
as well?
can see, yeah. Patient
Yes.
does not have history of fever.
Okay. I can see similar findings are seen on the AP projection, and I can see that there is a thick periosteal reaction along the distal end of the femur.
Mm-hmm.
Solid periosteal reaction. Uh, uh, Ma'am, I will. Can I have the age of this patient?
60.
60 years. Ma'am, I will keep in my differential that this could be due to chronic non-resolving osteomyelitis. Other than that, this could be due to Paget's disease in its mixed phase, where I can see both lytic and sclerotic areas. Other possibility, if this patient is a known case of any carcinoma, this could be due to metastasis, leading to this kind of mixed lytic and sclerotic. I would like to see if any previous images available, and I will refer this patient to go for MRI to see further details. And
Mm-hmm. It's only distal femur is involved.
no, ma'am, proximal tibia is also involved.
Mm-hmm.
Okay, this is
Both
a bone scan.
same patient.
Yes, ma'am. Ma'am, this is a bone scan of the same patient in which I can see that there is no uptake within the kidneys.
Mm-hmm.
So, and I can say that there is increased uptake involving the right knee joint, as well as areas of increased uptake is also seen involving the ankle joint as well. So, ma'am, this is likely a super scan, and I can see that there are multiple areas of uptake involving the vertebrae, as well as the sternum, uh, and the base of the skull.
Mm-hmm.
So, as well as the sacroiliac joint. Ma'am, possible differentials include Paget's disease, as well as other possibilities of hyperparathyroidism or metastasis.
Okay, if I say you that you have to do simple, it's a young, it's, no, no, sorry, 60 years old male patient. And if I say you, can you do a simple test for to rule out any one of the possibilities what you have mentioned?
Ma'am, serum alkaline phosphatase can be done to rule
And
out
okay, then you will rule out the
calcium and
Paget's.
uh,
And
ca-
any other differential you could rule out in male patient of 60 years?
ma'am, yes, ma'am, prostate metastasis. I'll go for the serum marker, the prostate tumor marker, um, PSA
Mhm.
levels to rule out the
Yeah,
possibility.
next case.
Okay, ma'am, this is Excel. This is a CT chest without contrast. Excel slices are provided.
These are limited images. Scroll up and
Okay.
down.
Yes, ma'am. I can see that there is an area of there's an uh, there's an outpouching along the uh, anterior. I can see there is a well circumscribed lesion involving the anterior mediastinum. Um and it has no internal differential density within it. Um, uh, no significant mediastinal lymphadenopathy seen. So I would like to go for contrast study for further evaluation of this lesion.
Mm-hmm. Take the images.
Yes. So the lesion has internal area of heterogeneity with central necrosis and enhancement, peripheral enhancement. Multiple septa are also seen within this lesion. Uh, the lesion does not show any vascular invasion or vascular thrombosis. Um, so I would like to know the history of this patient. This anterior mediastinal mass could be a thymoma or a lymphoma. Uh, so I would like to know the age of this patient and any history available.
30 years old female patient
Okay,
with,
young female patient.
yeah,
Uh, Ma'am, in my routine practice, I would like to see the lung window
okay.
as well as coronal images, sagittal images.
There is no provision of lung window, I think.
Okay. Okay.
So, if you want to select top differential, what it should be,
Uh,
and how will
ma'am,
you rule out other differentials on the basis of the image
ma'am,
appearance of the.
Ma'am, this is likely a case of thymoma. I would like to know
Mm-hmm.
the history if this patient has any weakness or drooping of the eyelid to rule out presence of myasthenia gravis in this
Okay.
case.
And other differential is?
Ma'am, a lymphoma, but it is less
And
likely.
other differential is?
Germ cell tumor, but I cannot see
Uh,
any calcification
yes.
or.
Okay. How much time we have now?
Ma'am, 2 minutes.
Okay, you go ahead with this case and then we will finish
This
with
is
you.
the X-ray chest frontal projection of a skeletally immature patient, in which I can see that there is generalized increase in the bone density, and I can see the clavicles as well. Uh, no definite lesion is seen within the lung parenchyma. CP angles are clear. There is mild prominence of the right hilum, and cardiac contour appears to be normal. So I would like to know the history and the age of this patient, keeping in view the diffusely increased bone density. This could be a case of osteopetrosis, pycnodysostoses, or ma'am, any underlying renal osteodystrophy. If this patient has any history of renal failure or any other.
If I say you review your chest X-ray, please, and patient does not have the bone density is projectional.
Okay. Ma'am, okay, I'll start again. This is X-ray chest frontal projection, in which I can see that the right hilum appears to be bulky, and the
Mm-hmm.
left hila is also prominent. Um, Ma'am, can I do windowing as I cannot see definite lesion within the lung parenchyma? Bilaterally large hila in this young patient. And this could be due to, ma'am, this could be due to possible differential of this enlargement of the hila could be due to lymphoma, tuberculosis, or sarcoidosis.
Mm-hmm.
I would like to review I would like to know, review if any previous imaging available. I would like to know the history of this patient and would further advise CT with contrast for
Patient
further.
present with recurrent chest infections and so young patient looking at the chest X-ray, you can see there's no fluid of the
Yes.
humeral head. So
Okay. Ma'am, with the recurrent infections. Okay.
Ma'am, time is up.
okay, okay. Anyone want to take up this case from like whoever is looking or listening?
Ma'am, can I try candidate one?
Yeah, yeah.
I can appreciate radio density along the right heart border,
Mm-hmm.
which is not silhouetting the right heart border, neither the
Mm-hmm.
right hemidiaphragm, along with bulky right hilum.
Mm-hmm.
So considering the history of a young patient with recurrent infections, it can be a patch of pneumonia. My differentials would also include an area of sequestration, and I would like to further investigate it with CT chest with contrast.
Yeah.
Um, so on these slices, I can appreciate a dense area where it is also supplied by one of the main pulmonary vein is approaching this area.
Mm-hmm.
Yes, but and also a branch vessel is arising from the descending aorta. So this is a
Perfect.
case of intralobar sequestration.
Perfect. So next question is, what are the types of sequestration?
Intralobar and extralobar sequestration. And
What is difference between these?
intralobar sequestration is a part of the lung parenchyma and hasn't got its own pleura. And it is the venous drainage is into one of the pulmonary veins. While for extralobar sequestration, it is entrapped with its own pleura, and drainage is into one of the systemic vessels like IVC or azygos.
Perfect. And
While arterial supply is always from the descending aorta for both of them.
which is more associated with cardiac abnormalities or cardiac defects or
Extralobar,
yes.
but
So
that is
yeah,
less common.
that is yeah. So yeah, we discussed this case actually by asking you questions as well. This is the intralobar sequestration and the typical history when the examiner will want to help, as I did in chest X-ray, was First of all, candidate three, did you asked me about two times about the age of the patient, and it is a crime when you see that there is epiphyses are not joined yet. So just don't like if the examiner is like strict, so he will mind that bit that you are asking without looking at the that they are not joined. It's a young patient, so try to avoid asking the age of the patient when you see the X-ray and you know it's a child. Number one. Number two is that uh, number two is that when I give you history, that's a recurrent chest infection in a young patient of with a chest X-ray. Always remember the sequestration, because a typical history they will definitely give you. Without that, it's impossible to reach the diagnosis. You will also always say it's like a pneumonic patch there, and obviously, if there's a recurrent, you will go for CT scan. Otherwise, in children, you don't go for CT scan in children so easily and quickly. But in recurrent chest infection, child, so you have to go for. And candidate one, you did really well in this after looking for the vessels and everything. Yeah, it was right. So this was the sequestration. I am not looking at the chat. If there is any question, please ask through the mic. Okay, and this was thymoma. You did pretty well, candidate three. Straight away, this was thymoma. But only objection here is that when you mentioned that there is a, first of all, you mentioned there's an area. Don't use those words which can create problem for yourself. If it is a mass or lesion, say it is a mass. Okay, don't say area and then further then
Okay.
you reach to the lesion. Okay, but in first instance you said area. It's a proper well defined mass. Always describe it well defined, this density mass. Okay, then you did really well. You mentioned there's no calcification, no this, and you ruled out germ cell tumor many times when you were explaining. But when I asked you differentials, you're not saying it. You are just picking two differentials, thymoma and lymphoma. And then I particularly asked what else, and then you said germ cell. Because candidate want to know that you are knowing the things, and you are there because you want them to know that you know your subject. So always, if you know that there are three, four differentials of anterior intestinal mass, just try to be more verbal in this when you are explaining. Otherwise, it was very well. It was good. No, nothing much to add in it. And yeah, this is the case. Mostly these cases are just for the discussion, like if the patient is this age, 60, male. Obviously you did really well in this alkaline phosphatase simple test, PSA, and they ask for the PSA simple test. The only learning point in this is you less explain the bone scan. You straight away said no renal uptake. First you explain that where the uptake is, and then in the like further you explain there's no renal uptake. That's why super scan, and super scan is mostly in this, and try to, when there is less to elaborate more on the image, then try to give idea to the examiner that you know your subject by explaining and giving the three, four DDs that he knows that you know that super scan is in this. Do you understand what I'm saying?
Okay.
Four or five differentials of super scan should be on your fingertips, and then you narrow down to the prostatic cancer. Okay, yeah, this was, you did really well. You reached by looking to the coronal images to the hernia and then anterior abdominal wall hernia with the, but the name of it is, anyone knows the name? Spigelian
Ma'am, is
hernia.
it Richard's hernia?
No, Spigelian
Spaghetti.
hernia. Yeah. So it's between the external oblique and transversus abdominis muscle defect, and then it caused the mechanical obstruction, and then you straight away refer the patient to the emergency surgical department. And most of the examiner wants to listen, that wants to hear that you say that I pick up the phone and convey my findings. So anyone can take want to take this case, or just tell me the differential or any diagnosis what they have in their
Ma'am,
mind.
can I say my opinion?
Yes.
This is a tooth-like calcification in the
Yeah.
pelvis. So if the patient
Perfect.
is having pain, this can be torsion due to dermoid or ruptured dermoid. So this patient needs CT for evaluation of this
Yeah.
abnormality.
So yeah, this is the dermoid case, and if the patient, you will not directly go to the CT. Obviously, you will ask for the history of the patient. If there's no surgical emergency, just a pain on and off, you will refer the patient to the gynecological department for the plain ultrasound first. because this is also they want to know that where you are referring the patient. If there is no emergency, if there is emergency, obviously patient will not have X-ray. Yeah. If there's a torsion, patient will not have X-ray for that. So if the patient came with the pain, on and off pain in the left hemipelvis, so they did X-ray, you find a tooth-like opacity straight away, and for candidate 3, the joint is fine. There's nothing problem in the neurosclerosis or nothing. I did not stopped you when you were explaining, because there are examiners who will not help you in the films, and there are some examiners who will definitely help you. So it's personal at that time, just to give you the idea that they will not say anything, and they will like let you go where you are going in that film. So this is dermoid, and you will refer the patient for ultrasound and gynecological assessment. So yeah,
Okay.
thank you very much, candidate 3. You did really well in rest of the
Thank you,
cases
ma'am. Thank
except
you
this.
so much.
Yeah. So who is candidate 4?
Me, ma'am. Assalamu alaikum.
Walaikum Assalam. Any questions from, yeah, or we can do it, read it the chat in the end if there is any in there. I don't know if somebody is putting some questions in the chat. Okay, so this is your first case, and candidate 1, are you keeping the time, please?
Yes, ma'am.
Yeah. So this is your case. Yeah, your time starts now.
Okay, ma'am. Ma'am, I have requested control. I'm presented with HRCT lung window, in which I can see bilateral ground glass haze, interlobular septal thickening in both lungs with subpleural sparing. And it is more in the periphery of the lung. There is fissural thickening also. And I can see nodules along the fissures on both sides.
Mm-hmm.
And multiple nodules also in both lungs. So I would like to know if this is a middle-aged female patient, and I would also like to see the mediastinal windows to see any lymphadenopathy to suggest sarcoidosis. Mhm. So, ma'am, can I see the mediastinal window?
Yes.
So there are bilateral hilar and mediastinal lymph nodes in paratracheal. I would keep the sarcoidosis as my first differential, as
Mm-hmm.
there are perilymphatic nodules and lung parenchymal disease as well as mediastinal disease. So stage 3 sarcoidosis, I would inform the finding to the referring clinician, ask for the previous records and to see the progression of the disease, and correlate with the serum angiotensin enzyme and calcium level, and refer this patient to pulmonology MDT for further evaluation.
What are the stages of sarcoidosis and what stage it is?
Stage 1 is only lymphadenopathy. Stage 2 is only intrapulmonary. Stage 3 is both, and stage 4 is fibrosis, and stage fibrosis of the lung. So this is stage 3.
Okay. Yes, we'll go to the next case then.
My screw. I cannot see it on the screen. Okay. I'm presented with the frontal abdominal X-ray in a skeletally mature patient, in which I can see significant amount of air in the pelvis with
Mm-hmm.
a probably air fluid level in the dependent part. I wonder if this is air within the bladder. I would like to ask the history of the patient. There is mild scoliotic deformity of the spine in the
Patient is
generative chains.
diabetic and 80 years old.
So a diabetic patient, old age, mostly immunocompromised, this can be emphysematous cystitis, and the diabetes are mostly confronted with this condition. So I would like to ask if there is history of dysuria,
Excuse me.
and correlate with ultrasound of this patient, and renal function test, and urine analysis. I cannot see any air within the renal shadows or pelvic basal system. However, there is air within the bladder, which suggests infection with gas-producing organisms and emphysematous cystitis. I would correlate my finding with the ultrasound. There is
Okay.
also some thickening along the pelvis. So this is the CT of the same patient?
Yes.
Okay. I can see airflow level as well as air within the bladder wall, which is grossly distended. I cannot see any free fluid. And I'd like to see the kidneys as well. No, there are no kidneys. So this is likely a severe urinary tract infection in a diabetic patient, leading to emphysematous cystitis. The urethra is also thick-walled. And is there any history of trauma?
No.
No. So this is likely infection with gas-producing organisms in a diabetic patient, uh, leading to emphysematous cystitis. I would urgently inform a finding to the referring clinician for immediate start of the antibiotic therapy and refer this patient to urology.
Okay. So, yeah.
Presented with frontal knee radiograph in an adolescent patient in which I can see a lucent lesion with sclerotic margin in the central portion medulla of the proximal tibial metaphysis. It has got narrow zone of transition. I cannot see any periosteal reaction, cortical break, or soft tissue component, and well-defined sclerotic margins. I would like to ask if the patient has any chronic fever or anything like this. Then if there is history of fever, then this can be Brodys abscess. Otherwise, it can be uh, mm, uh, non-ossifying fibroma. However, non-ossifying fibromas are more eccentrically located. It can be simple bone cyst. However, this is less sclerotic as the simple bone cyst is less sclerotic as compared to this lesion. So I would be looking at the previous reports if there is this lesion has been persisting or new, and any history of fever to suggest Brodys abscess.
Okay. Next case.
This is not scrolling.
Please ask. Yeah. Please scroll. Yeah.
I have already asked
Yeah.
about
Yeah.
the.
Scroll.
This is not scrolling.
Click the
I
image and yeah, you are
okay,
scrolling.
okay. I'm presented with axial CT, non-contrast. I would first scroll from top to bottom. In my first scroll, I cannot see any obvious abnormality. The basal cisterns are patent. Gray white matter differentiation is preserved. There is no midline shift hemorrhage. Small punctate calcific density seen in the basal ganglia. Can I know the history and age of this patient?
Patient is in 50s and presented on and off confusion symptoms or not
There is a vaguely
specific.
defined hypodensity in left top parietal white matter. Mm. In these images, I cannot see any other abnormality. Can I see contrast images to further?
Yes, please. Yes, you can.
Okay, yes, I've taken the contrast. There is some hypodense area in the top parietal region and the left cerebral hemisphere within the white matter.
Ignore it.
Okay. I scroll down, the arteries of the circle of Willis are patent. There is no crowding at foramen of magnum. There is a small hyperdensity in the central intercellular area in the FARCs.
Patient also developed recently visual disturbances and seizures and high blood pressure.
I wonder if this can be an AC aneurysm leading to some occult bleed, subarachnoid bleed. I would again look through the areas to see if there is any hyperdensity. Uh, since this is a contrast study,
In beginning, you mentioned some hypodensity.
yes,
In-
in the you said to ignore this
no,
high.
no, yeah, ignore this one. But is there any other area of concern? Otherwise, we could move.
There is a bilateral posterior occipital lobes, there is hypodensity.
Mm-hmm.
So this can be some problem with autoregulation of blood pressure and posterior reversible encephalopathy. I would
How
further
will you
like
proceed
to
further
I would
to
like to
confirm?
proceed with MRI with MRI.
Okay, just leave the mouse for a second.
Okay. Okay.
Yeah.
Uh, this is T2 weighted axial MRI images, in which I can see high signal intensity within the posterior and anterior parietal and occipital lobes, as well as in the cerebellum. Some hyperintense areas are also seen in the brainstem. So bilateral asymmetrical white matter hyperdensities in the posterior parietal occipital regions as well as left frontal region suggest posterior reversible encephalopathy syndrome. However, I would like to also see this on contrast enhanced images and DWI.
Yes, please. And how will you further take this patient?
Um, on contrast enhanced, there is no obvious enhancement.
Mm-hmm.
On DWI, can I see the DWI?
Yes, please.
There is no restriction. Uh,
So
there
with
is subtle
like
restriction, areas
so
of
now
restriction.
you are with one differential. What is it?
Posterior reversible encephalopathy syndrome.
And what is the treatment of this?
Blood pressure monitoring, control of the blood pressure, and intensive monitoring of the vitals, and then follow-up imaging to see if the abnormality has
Okay,
resolved.
this is the next case, please.
And this is the frontal radiograph of the right leg in a skeletally immature patient, in which I can see that there is the knee joint, the hip joint space is preserved and the femoral head contour is well preserved. I cannot see any obvious fracture. There is a subtle area of periosteal reaction along the medial side of the femoral diaphysis.
Mm-hmm.
Can you zoom it, ma'am?
Yeah, please.
This is
No,
getting smaller.
yeah, this one. Zoom this one. Yeah, 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 yeah,
This is the maximum.
yeah,
So I would like to see this on other orthogonal view.
yeah.
Uh,
Take the pelvis.
in the pelvis, X-ray pelvis, there is slight sclerosis over the neck of the femur and the proximal metaphysis of the femur. In a young skeleton, this can be some osteoid osteoma. I would like to ask if there is history of night pains.
No, no.
If it is a runner, this can be some stress reaction, or if there is any history of
You want
fever.
to review for ignore this, and you want to review
Mm,
the film
uh,
again.
the first one
Both,
or this?
both.
Okay. Um, there is some irregular sclerosis over the ileum
Mm-hmm.
here, and surrounding soft tissue,
Mm-hmm.
swelling in a young skeleton.
Mm-hmm.
I'm concerned about any aggressive etiology because it has got irregular patchy areas of leukocyte and
What it could
sclerosis.
be?
It can be Ewing's sarcoma in this young age. I would further like to characterize this abnormality through CT or MRI with contrast. So this is coronal fat set T2-weighted MRI, in which I can see a large area of abnormality centered on the right ilium with the this is contrast enhanced study, which is enhancing with there is soft tissue component and uh, enhancement and marrow abnormality of all of the ilium. Uh, so this is likely a neoplastic etiology, most likely in keeping with the Ewing's sarcoma. The sacroiliac joint is normal and the edema is extending up to the acetabulum. However, the hip joint itself is normal. I would inform my finding to the referring clinician, advise bone scan, advise staging CT, and refer this patient to the sarcoma center for biopsy and definite histopathological diagnosis.
Okay. Do we still have time?
Only 15 seconds left, ma'am.
Okay, so if we should like start from here now because 15 seconds is very less for a
Mhm.
film. Okay, stop controlling
Okay.
the screen. Yeah. Okay. Yeah, you did really well after I helped you a little bit because in if the examiner is not helping, he could change the film and
Mhm.
like by giving you whatever marks he would want to give you. So yeah, it was Ewing sarcoma. Rest of you did really well after that when we discussed it. Yeah, but on the plain film, if you see this image again, you could see a
Mhm.
periosteal reaction here now. Do you?
Yes, it's very
Because
subtle.
you fix yourself to this bit. My objection
Mhm.
only in this plain film explanation was that you fixed yourself to this and you remained here. You did not see other bones very
Mhm.
well until I said you to review the other bones because in this it's pretty much visible, but in this as
Mhm.
well, always look from
Mhm.
cortex to cortex and look for
Mhm.
some periosteal reaction. It is quite visible now if you
Mhm. Yes,
retrospectively
ma'am.
go to the yeah. So yeah, other than that, the what next is you explained very well. Sarcoma center for further and CT staging very important in you have to say this to gain marks. Okay, this was this was press posterior reversible leukoencephalopathy. Yeah, yeah. In the beginning, you just had some difficulty, but it's normal to have because it's not very obvious. But whenever you get a history of high blood pressure and symptoms like headache and confusion, so reach the diagnosis of press. But otherwise, it is history based. It's difficult to assess without history. It was the
So, ma'am,
press.
we will be given history of this sort of
Not
case in
every
exam.
case. Like this case, if this is the case, just in some cases the examiner would help. Just I did. Okay.
Mhm.
Review and they know that the case is difficult. But if the case is straightforward, they will not. Just like the tooth like density in the X-ray. Why would the examiner help in that case? Because it is typical tooth-like. He will not. Because because if you are not even mentioning that, it could be a possibility.
Mhm.
Understand in the differential, then might be he is helping and but if you are straight away ignoring that shape of typical, so
Mhm.
he will know that don't know or you're not explaining it well. So yeah, it is press and then it is the Brody's. It was right. It was straightforward. They could ask MRI features of Brody's abscess, especially what is the penumbra sign. And I actually I'm not remembering that, but I remember the question. It is very important question from the exam point of view. Just go on the Radiopedia and check afterwards. What is the penumbra sign?
Mhm.
It's on T1 weighted image some enhancement, but it's why it is called penumbra. Please have a look on it. And yes, this is emphysematous cystitis, and this is emergency. You have to mention that I
Mhm.
will pick up the phone, I'll call, and CT scan further. In CT scan, it was, and they could ask for obviously grading of emphysematous pyelonephritis if they want to, and further check your knowledge about it. Otherwise, it was straightforward. And usually they ask on the plain films first to see and the candidate that whether they give the importance to the plain film or just want to go on a CT straight away. Yeah, this was right. This was sarcoidosis. And you explained it very well. This was stage three. Yeah. And you did mention that you will do ACE test, and yeah, everything was okay in this case. There's nothing much to add in this case. So, yeah, any other question from any other candidate or anything else you want to ask? Because candidate four, you did really well.
Thank you, ma'am. It was a very
Yeah,
useful session. Thank you for your
yeah,
precious
keep
time.
practicing. I did. Maybe I did sound harsh on few of the things regarding like explaining that why the examiner will not
No, no,
helping
not at
and I
all.
was not
But
helping it. Just don't mind any of the
mm,
candidates, please. So it's
but
just
Ma'am,
a
just
thank
let's
you
see
practice.
the
so
exam
much.
scenario.
Yeah.
Ma'am, I have a
So
question.
yeah, yes, please.
Ma'am, in the press case, there were multiple foci which were showing diffusion restriction. Ma'am, those were watershed infarcts?
Yes. Yes,
Oh,
it's two or three things can be, together. But in
got
that
it.
case, just I mentioned her, ignore that. So it means that they help it a little bit in the exam like this.
Okay.
Just, just to for the time saving as well and